So these are my disclosures. So as we know, neoadjuvant therapy is reserved for those patients who are cisplatin-eligible, and it's recommended for those patients who are T2 disease or higher. The patients who should not receive cisplatin-based chemotherapy are those with renal impairment or other comorbidities such as peripheral neuropathy, cardiac disease, which would preclude proper hydration, poor performance status. So those are the real things that eliminate patients from that particular treatment. But we know that we do have a survival benefit for those patients who undergo neoadjuvant chemotherapy. It's generally about 14% overall. This shows a summation of a number of trials, including those from the EORTC, those from SWOG, showing a hazard ratio of about 0.87. And again, this is the survival curve from that particular study of platinum-based chemotherapy. So how have we tried to improve neoadjuvant therapy and, of course, adjuvant therapy for urothelial carcinoma? Well, what about checkpoints? So the thought is to move checkpoints into the adjuvant state, and CheckMate 274 was a phase 3 study that took patients who had high risk for recurrence after radical cystectomy and treated these patients with 1 year of nivolumab at 140 milligrams Q2 weeks. I think most of us use a 480 milligram schedule monthly. That's considered to be equivalent. And then patients were observed after that period of time. The patients had T2 to T4 disease who had neoadjuvant chemotherapy. The patients with T3 or higher disease or node-positive disease who had not had cisplatin neoadjuvant therapy were also eligible, so it was really two different cohorts of patients. They had to have surgery within 120 days. So that would capture those patients who are cisplatin ineligible. As we know, there was an improvement in disease-free survival, and this seemed to be more pronounced in those patients who were PD-L1 positive. So it's about a 12-month difference compared to placebo in for the ITT, and then for the PD-L1 positive, it's even more pronounced. It's 56.2 months versus 8.4 months for the placebo. So that's a pretty stark difference between the two. I don't believe the survival data is actually read out at this point still, correct?
It probably will never read out based on the statistical plan.
Right. So that's unfortunate that we don't have that as overall. If we look at distant metastasis-free survival, same pattern, Nevo 47 months, placebo for 28 months. For the PD-L1 positives, for Nevo it's not reached, placebo it's 20.7 months. The Ambassador trial, which was run by Andrea Paulo, looked at pembrolizumab at 200 milligrams every 3 weeks for a year. This was open label. Same thing with the atezolizumab trial that was of a similar design. As we see, this is a similar group of patients with metastatic renal cell carcinoma, excuse me, with high-risk urothelial carcinoma. I was letting my mind wander for a second. Primary endpoint was overall survival and disease-free survival. Secondary endpoints, overall survival. Similar disease-free survival data. OS was not met, but that was because of the fact that this trial was, the label was patients were then permitted on the observation arm to receive pembrolizumab when nivolumab was approved by the FDA, and that trial was matured. So this will never show a survival benefit because of the crossover. So adjuvant. Now, what about moving this up to the neoadjuvant setting? This is a presentation and also New England Journal of Medicine paper that came out at the same time looking at the NIAGARA trial. This trial took patients who were T2 or T4 disease or better. They had to have urothelial carcinoma. They also were allowed to have differentiation to other subtypes as long as your predominant subtype was urothelial. Patients had to have been eligible to receive a radical cystectomy, and they were randomized to durva gem-cis versus gem-cis. And then if you were on the durva arm, you received durva for adjuvant 8 cycles. So that's actually 12 months of adjuvant or neoadjuvant perioperative checkpoint therapy, similar to what you would see in the other two adjuvant trials in total duration. But no adjuvant therapy in the control arm, which this was a predefined analysis. Now, importantly, 3% of patients actually did receive adjuvant Nebo, so even though this was not prescribed in the study. So this is effectively no treatment for all patients. Primary endpoint, event-free survival, as well as pathological complete response rate. Secondary endpoint was overall survival. Patient characteristics. Patient characteristics, as we see, T2 disease, well-balanced, higher than T2, 60%. PDL expression high, 70%. Histology, predominantly urothelial. Only about 14% had divergent or differentiated subtypes. Wasn't clearly defined exactly what that was. So this is the event-free survival. Hazard ratio is 0.68 overall. And then the overall survival hazard ratio is 0.75, 25% reduction in the risk of death. So how is this different from our standard of care? Well, number one, patients who had a pathological complete response, which was a higher rate in this particular trial, they would have continued their adjuvant therapy. So the question is that necessary? Number two, would these survival curves have been tighter had there been adjuvant therapy in the control arm? Answer is unknown, but nonetheless, this is an option, I would say, for those patients who are cisplatin eligible. Now moving on to cisplatin ineligibility. This is a presentation we had at ASCO GU now 2 years ago. This was the EV-103 cohort H study where patients were treated with enfortumab vedotin. As we know, that's an ADC with Nectin-4 as its target. And these were patients who were cisplatin ineligible based upon renal function, based upon other causes as well, hearing loss, peripheral neuropathy, and they had to have more than 50% urothelial carcinoma. Patients received neoadjuvant EV monotherapy for 3 cycles. Then they went on to receive a radical cystectomy, and they were followed up. There was no adjuvant therapy on this particular study. 20 patients were treated. The median time from enrollment to diagnosis was 1.6 months. Predominantly pure urothelial carcinoma, but there were some patients with squamous variation and other subtypes, small percentage of patients with micropapillary disease. Remember, this is only 20 patients. So if we look at the criteria for cisplatin eligibility or ineligibility, we see that about half of patients had a creatinine clearance of less than 50. 1 patient had an ECOG of 2. 40% had grade 2 or greater hearing loss. And if we look at hearing loss and grade 2 and creatinine clearance, 1 patient had both of these particular criteria. So looking at the pathological complete response rate, it's 36.4%. The downstaging rate is 50%. That means it defines as the presence of T0, TIS, TA, or T1. And this is complete disappearance of disease. So we did have 3 deaths on study. And 1 was a cardiac arrest, which was related to the radical cystectomy plus pelvic lymph node dissection. There was also a pulmonary embolus, which was related to the radical cystectomy, thought not to be related to EV. And then also acute kidney injury, which was not thought to be related to any of the events or the procedures on study. Nonetheless, it is concerning. This is a more sick group of patients overall than what you would see with cisplatin-eligible patients, at least you would assume. Even though you're using a smaller dose, or at least a more limited dose of EV, only 3 cycles and on days 1 and day 8, peripheral neuropathy does occur. 8 patients had that, 36.4%. Skin rash, 63%, 2 of which had grade 3 skin rash. Hyperglycemia was seen in 5 patients. Ocular events were seen in 9.1% of patients, and there were some infusion-related reactions as well. But these generally are dry eyes and can be easily treated with drops. Hyperglycemia, this again is non-fasting. I don't believe there are any doses that were held due to hyperglycemia. As you know, you have to have a glucose of less than 250 to be treated on a given day. So this just basically compares, what we would see with different studies looking at pathological complete responses. Back to Dr. Grossman's seminal study with MVAC, 38% pathological complete response. The VESPER trial, 42%. Same thing with the GTUG trial with GemCis, 36%. And then if we're looking at pembrolizumab as a single agent, 37% from Dr. Nietzsche's study in cisplatin-eligible and ineligible patients. So very, very similar results to what we see in the situation. The question is this hitting the same clone or the same group of patients? Not really clear. The cohort L was just simply an extension of cohort H, where we took patients who had cisplatin ineligibility, treated them in the same fashion preoperatively, did the surgery, and then gave them postoperative therapy. And again, primary endpoint was pathological complete response rate and event-free survival, disease-free survival, overall survival, all included in secondary endpoints. So neoadjuvant phase, then to the adjuvant phase. So larger cohort of patients, 51, 82% completed all 3 cycles of therapy, and then 82% went on to surgery. And as we see, the same thing, a pathological complete response rate of 34%, disease-free survival rate of 42%. So treatment-related adverse events, again, very, very similar to what we saw before, about 27% with peripheral neuropathy, if we look at skin reactions, 56% had some form of skin reactions, and we lost 1 patient due to Stevens-Johnson syndrome. There were no delays in surgery, and most common grade 3 surgery events were anemia, ileus, and urinary tract infection, as one would expect in this situation. So again, the neuropathy is a problem, and this is something you would think about if somebody's going to be potentially cured by treatment in the future. How long is this neuropathy going to go on? Because in my experience, that neuropathy very rarely gets better, usually persists. So what are we looking at in the future? Well, we have some trials that are going to read out hopefully within the next year. I talked about this study yesterday, which is EV303 Keynote 095. These are 2 different groups of patients, those who are cisplatin ineligible with muscle-invasive disease or cisplatin eligible, who basically declined cisplatin, treatment naive, underwent a TURBT, the stratified based upon their eligibility, the stage of disease, and the region of treatment. 3 different arms, pembro at 200 for 3 cycles, observation, or pembro plus EV. And then they go on to pembro postoperatively, observation, or pembro plus EV. The VOLGA trial is asking a slightly different question. This is in a group of patients who are platinum ineligible. There is no refusal to undergo cisplatin-based therapy. 3-arm trial, durva-tremi, as we know, tremi is a CTLA-4 inhibitor, plus enfortumab. Arm 2 is durva plus enfortumab, and then finally going right to cystectomy. This is actually, I was a little bit more surprised in trying to sign patients up for this trial that a lot of patients did not like this arm. And I was surprised by that because it's standard of care. They said, well, I don't want to be randomized to cystectomy-only arm, but you're going to get a cystectomy-only anyway, which kind of made no sense to me when patients came to me with that, but a lot of them were very uncomfortable with it. And we actually had a trial in SWOG that had exactly the same problem, that was looking at a checkpoint plus carboplatin and gem in the neoadjuvant setting in cisplatin ineligible, and the accrual was dismal on that. So the patients are then eligible to go on adjuvant, durvalumab or durvalumab alone, or no adjuvant treatment. So in conclusion, neoadjuvant cisplatin-based chemotherapy is still the standard of care for patients with muscle-invasive bladder cancer. The NIAGARA trial still is yet to be FDA approved. Adjuvant immune therapy should be considered for those patients who have undergone neoadjuvant chemotherapy with residual muscle-invasive node-positive disease at cystectomy, or T3, T4, or N-positive disease who have not undergone neoadjuvant chemotherapy. And it remains the standard of care for cisplatin-ineligible patients. Novel agents are being evaluated in this disease state, and the role of ADCs in the neoadjuvant adjuvant treatment of urothelial cancer is still evolving.